That's why the numbers are less, Abby, because a lot of people are just watching it on YouTube and not bothering to come in. Do you know what I'm
Yeah,
saying? Do you know what I'm saying?
yeah, yeah.
I could not televise it on YouTube, but I don't see the point really. I want
No,
the
that's
most
okay.
people to see it.
Yeah, that's fine. So should we start?
Hold on, I'm still putting it on YouTube.
Okay.
Are you hurrying me? You can say,
No,
hurry up, bozo.
no, I'm not.
The main thing I gotta do is make sure it's on the internet. Okay, we got it. Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett broadcasting here. We're not waiting. Let me change the screen real quick. Okay. But yeah, broadcasting from Miami Beach here. It's the home of the webcast. And today we have the honor of having the India Neurosurgical Student Group with a couple of good webcasts and a long old-time friend, Abby Shah, close associate of Dr. Atul Goel, who helps arrange a lot of conferences and is here today to talk about, what she went through med school and what she would do if she was a med student today. Okay, welcome, Abby.
Thank you, John. So, yeah, you can see my screen?
Yes, yeah, you want to make it presentation mode? There you go, perfect.
Yeah, yeah. So, hi guys. I'm a neurosurgeon at Mumbai. I'm at St. GS Medical College and KM Hospital. And now it's been nearly, I think, 20 years since I've started neurosurgery. So, what you need to understand is neurosurgery is not just a branch. It is not just a subject. It is not just something that you pick. It is a way of life. And it involves a large amalgamation of philosophy, technique, and technology. So, first of all, before you plunge into this subject or think of plunging into this subject, you have to identify whether you identify with the subject. And these are some of the basic things that I feel you must have as a medical student to even think of going into neurosurgery. One is love and passion for the subject. You have to love the human brain and the spine. It's only then you will dedicate yourself to this subject. Believe me, it's not easy. You need a lot of physical and mental stamina, but it's worth everything. That I can tell you. There are some difficulties. It has a long learning curve. You have to have some manual dexterity. You have to have surgical skills because, and probably by the time you finish your med school, you will know which way you're inclining towards. You have to have an inquisitive mind. You have to have the ability to take quick decisions and to manage your time. You need to have confidence in yourself because this subject, it gives you highs and it gives you lows. There are times when you will be thrilled that you were able to do the case, and there are times when the case will knock you down. So you have to be prepared for both the things. And so you have to have that much confidence, little bit overconfidence in yourself to live with this subject. And you have to have empathy for your patients because, mind you, some things there are no answers for some things. Patients are sometimes in a debilitated state, and it is difficult to deal with them. So you have to have empathy for the subject, empathy for the patient, and a faith in the subject. So as I've started this journey into neurosurgery. I knew what I wanted to do neurosurgery when I was very young, probably at the age of 15 or 16. To tell you the truth, I joined medicine because I wanted to do neurosurgery. So I knew pretty well, and the brain always fascinated me. So in a way, it was little. I mean, I didn't have too much to think, or I didn't. It was a very natural flow for me. But people who are undecided or people who don't know, so the first thing I would advise is in your first year, when you're doing your anatomy, is you attend your dissections. Do not neglect the anatomy of the brain. Do not neglect the anatomy of the spine, because this is your core basic. This is the core foundation of a neurosurgeon. Neurosurgery is anatomy guided. So you can see this picture. This is of Sushrut. So what you cannot study from textbooks, what you can feel with your fingers when you're doing the dissection. And it is absolutely essential to know the anatomy of the brain, because there are a lot of techniques, a lot of skull-based techniques that you have to know, a lot of approaches to intrinsic brain tumors that you understand when you understand this three-dimensional anatomy of the brain. So, it is like without laboratories, men of science are soldiers without arms. So, anatomical dissections are a core part of the art of neurosurgery. As is your anatomy, so will be your surgery. So, and now you have the time. I mean, when you go into neurosurgery, when you're a neurosurgical resident, you might actually not have that time. And that time you will think, why didn't I pay too much attention before? So, when you do it now, when you're doing your before surgery, go a long way. Believe me, I read a lot of brain anatomy when I was a medical student because it just interested me. And it made things very easy for me when I actually went into neurosurgery. So anatomy is one core part, and build a strong foundation of neuroscience in your brains. This involves in understanding neurophysiology, it involves clinical neurology, and you have to also understand a lot of radiology. So physiology is you have to understand how the nervous system works, you know, because after all, neurosurgery, neuroscience, neurology, it's all mathematics. You cannot take a decision just seeing the radiology. You have to correlate the signs and symptoms with the radiology to see whether the patient needs surgery or does not need surgery. The most important decision you make as a neurosurgeon is the decision for surgery. Doing surgery is another part, but just the making the decision for neurosurgery is a big part of this subject. And how do you do that? When you have a very strong basic core. So do not neglect your physiology of the nervous system. The neurological examination is really important for neurosurgery, because neurosurgery is clinical. It involves a lot of clinical neurology. You have to know everything about neurology, then only you will become a good neurosurgeon. So these are things that you should not neglect as a medical student, because they will only help you as you go further. They will make your core basic foundation very strong, and it will go a long way when you actually start your clinical practice. The third thing nowadays is radiology. You are going to read the scans yourself. You cannot depend on a MRI report or a CT report. You have to have the ability to read them on your own and interpret them. And now with this AI coming in, you know, more and more important it is not to just rely on AI, because you're knowing the radiology, it does make a big difference, and it will go a long way in treating your patients. Another thing that you should do as a medical student is publish, because uh, I'm not sure whether you want to continue in our country or go abroad, but if you have to go abroad for getting into the branch of neurosurgery, you will not be able to do so without some basic research and basic publications on the subject of neurosurgery. So basically, scientific publication is an outcome of involvement and understanding of the subject. It has the power to change existing thoughts, and it contributes to the growth of the subject. So whenever you get an opportunity, you should try and publish even in your medical school, or even as you're doing your internship. So this was not there during our time. It has changed now, and this goes a long way in building your CV. Another thing that you should do is try to find a mentor. I'm sure where you are having good neurosurgeons who you can go and visit, even in your own medical colleges. You should go and see your department of neurosurgery. You should shadow someone you admire. You have to get a glimpse into the life of a neurosurgeon, so that you can decide whether you want to do this for the rest of your life. Because once you take a decision, you can't take it back. Second thing is you attend so that you get exposure to the field. Try to get a neurosurgical rotation. Once you are in it, you will know whether you like it or not. It is, either you like it or you won't like it. But before taking any decision like that, it's good to have, to see those kind of surgeries and to see if you have the love for it. Attend some neurosurgical meetings. Look at neurosurgeons interacting with each other. Look at the subject. Look at how many things are still, neurosurgery is an evolving branch. It has evolved tremendously in the last 20 years, but still there are things going on. And neurosurgery involves a lot of technology. So it is a subject that grows with the technology. And there is a lot of new technology coming into the subject. So, you should attend these meetings to get an exposure to this. Second is you must present papers in these meetings. If you have a good mentor, we all our neurosurgical meetings have a section where medical students can present. It just builds you up for what you're getting into the future. Also, another thing is there are a lot of medical societies, medical student clubs that are hosting meetings or workshops for neurosurgery where I have hosted too, where we teach how to drill, to make basic boreholes, to do a craniotomy, to do suturing, microvascular suturing vessels, to do white fiber dissection, to understand the anatomy of the brain. All this gives you an idea of how skilled you are or how skilled you can become, and whether you actually want to take this subject. So these are a few things that I think you must do so to understand whether you are entering into the right field. For people in India, so we have two options. We have a 3-year course and a 5 or 6 year course. The 3-year course you can do after you do your general surgery. Some people are not decided whether they want to do, neurosurgery. They sometimes decide after general surgery. So then they can take a 3-year course after general surgery. But I can tell you a 5 or 6 year course also works very well if you're 100% sure that you want to do neurosurgery. Actually, it gives you a longer time to engage in the subject and to evolve slowly with the subject. So sometimes both of them have their advantages, disadvantages. It is actually up to you. You can make a choice, but both these options are available. And so you have to plan your path, you have to plan your career. You know that there are entrance exams in India, and many of these institutes have their own exams themselves. So to get through these exams, they actually expect you to know neurosurgery. So that is why you have to get exposed and you have to read a lot of neurosurgery, read the anatomy, read some basics about the pathology, about the surgery, because you will need it for your entrance exams. And basically it is a fascinating branch, and it really fuels you, your if you love it, it's your life. It is as simple as that. You cannot think of anything else. But it does involve a lot of hard work. You must remember that. Long hours, hard work, and dedication. But once you're in it, it's absolutely the most brilliant branch in the subject. Thank you very much. John?
Let me unmute myself here. I'm going back to basics. Uh, yeah, come to think of it, Abby, uh, when I was in medical school, neurosurgeons were like strange people that we could never talk to because they were so busy. And I think it's been like that in most medical schools. Most medical schools, I think, neurosurgeons are considered gods, actually, I think, in most places. And they just weren't to be disturbed. And if we were lucky enough to talk to them, it would just be for a short amount of time. So the suggestions about mentoring, etc., are, I'm sure, well taken. How about Dr. Khan? How about you? What was your thinking when you were in medical school as far as neurosurgery? Did you decide, like Abby, when you were young, that you wanted to be a neurosurgeon first before even a doctor, right, Abby? You didn't even know you wanted to go in medicine, but you wanted to go into neurosurgery. And then you
Yeah.
discovered you have to go through medicine first.
Yeah,
That's a
John.
little switch in the decision making process. Because that's also my impression. Most neurosurgeons that I meet, they knew pretty early that they wanted to be a neurosurgeon. It wasn't like a snap decision on match day. Oh, I think I won't go into pathology. I'll go into neurosurgery. Or, most of the neurosurgeons, they knew from an early age they wanted to do it. But are you there, Dr. Khan? I just want to see if you want to relate your story.
Yeah,
Uh,
yes, sir.
yeah, can you relate your story about the evolution of your thought during medical school and neurosurgery? What were you thinking when you were in
Actually,
medical
I'm
school?
a pathologist, sir. I'm not a neurosurgeon.
Yeah, I know, but I want to know. Yeah, that's a good point. That's a good point. Well, I could twist that and try not to look like a complete idiot and say, how about pathology? When did you decide on pathology?
Actually, from the beginning of my MBBS, I was so much curious about the cause of the disease and the basic pathophysiology. I was very curious to know the pathophysiology of the disease. How does it happen? What is the process of the disease? So I used to read multiple books regarding the pathophysiology of a particular disease, and I was very much interested to know the cause of the, like, prognosis, how does it happen, and all that. So that is how I was, till my, like, I reached my final MBBS. I decided that I either want to take internal medicine or pathology, because I was curious to know the cause of the disease and the diagnosis and the process of the disease, pathophysiology and all.
Yes,
So that is how I decided to be a,
it's a totally different. Well, you have to go through a separate residency for pathology compared to internal
yeah,
medicine.
yes, sir.
Yeah, and the people I've run into, there was one student. He was applying to residency in cardiology and neurosurgery. And he asked me my advice because I knew him maybe 6 months. He did a lot of webcasting. And I said, my advice to him was like, if you don't know you want to be a neurosurgeon or not passionate about it, don't do it because you're going to need the passion to carry you through the difficult period. I would suggest going into cardiology, especially if you're not sure. Uh, because once you make that decision to go on neurosurgery, you're kind of not stuck, but it's be a difficult decision to get out of it. Would you say so, Abby? Also, about would you agree on
Yes,
that?
yes, I agree on that. There are a lot of, friends who sometimes, they change. They come into neurosurgery and then they don't realize it's not for them. But they do have an opportunity to change it within a month's time. But, in some places you might not have the chance, and then you have to wait another year before you, take the
Yeah,
test again
yeah.
and
But for
decide.
you knew right away, and you
And
were
I knew I knew when I was a kid. So
yeah. I think most neurosurgeons are like that. They kind of know, and it's
yeah.
and this gentleman is in cardiology now. And he's doing well. He went to Harvard. He was a very accomplished student. He could have gone. He could. He. That's right. He had to answer. He was accepted at BU neurosurgery and at Harvard in cardiology. I mean that is a good looks good on your resume if you went to Harvard cardiology. I mean that's fantastic, and the BU is excellent too for neurosurgery. But yet I said no. Go to Harvard. Go to Harvard. The name is going to carry you for the rest of your life. Everywhere you go, it's going to be with you. And you don't go into neurosurgery unless you're completely committed.
Mm,
It's
not crazy.
it's more of a lifestyle change to me, Abby. You know what I mean? It's like it's more than just a decision of what you're going to do most of the day. It's no, what you're going to do for your life.
Yeah. No,
It's
it is a
more,
lifestyle. Neurosurgery is a lifestyle. You have to be ready for it. I mean, it
yeah,
will always take priority in your life over everything else. Yeah, because you cannot say no. If something happens, something changes, you have to run immediately. You just cannot say no. Yeah.
yeah, yeah.
Yeah.
I think so too. So,
Yeah.
okay, Abby, thank you for giving your thoughts. And
Thank you, John.
yeah, and I'm sure a lot of neuro students are listening on YouTube that will take your words to heart. And okay, now we have the second presentation, Dr. Khan, pathologist from India. I bumped into her on the internet and she agreed to give her free time to educate, hopefully, people that want to be neurosurgeons that are kind of on the fence and don't know. But anyways, to get something relevant to students, we picked Abby to give a pathology series. This is the first of 4 series that are going to happen every consecutive time on Saturday at 8 o'clock India time. Okay, Dr. Khan, it's all yours. Oh, I think she may have fallen off.
Yeah, I think she did.
Well, Abby, we get to small talk.
Yeah, but then John, in a few minutes, I'll have to go. Okay. I
Yeah,
have to go
okay.
some-
No, thanks for your time, Abby. I really appreciate it.
No, no
Yeah, if
problem.
you have to go, just go, okay?
Yeah.
And no, we'll just wait. We'll wait for Dr. Khan to come back. Don't worry about it.
Yeah. No, I'm good now. I'll go in a few minutes.
Okay.
Yeah, she's back.
Okay, Dr. Khan, you're back. And we're ready for you. You're ready when you're ready. Okay. You're on your way.
Can you see my screen?
Yes, I can, but I need to share your presentation. Because you're seeing what we see, the Zoom screen.
Now?
No, you need to go to your PowerPoint now. Go to your
Yeah,
PowerPoint
I'm
and
in my
open.
PowerPoint.
Okay, but you're not sharing it. You need to open your PowerPoint, then go back to the share. You don't want to open Zoom. You want to open
Okay.
your PowerPoint. Okay,
Now?
that's good. Now put it on presentation mode, which is at the bottom. There's 4. There you go. There you go. Hey, perfect. Perfect. You got it.
Okay, so this is my first lecture in the series of Introduction to Neuropathology. In the first lecture, I'll be discussing about the basic principles and different cells in the CNS and how they respond to different stimuli, different insults in the body. So let us begin. What are the objectives of our presentation today? To understand the CNS and the histology and how it is organized, and to learn the pathological reactions of CNS tissue to injury, and to recognize the cellular responses. There are several cellular responses which occurs to different insults, to different cells in the brain, like neurons, glia, and the meninges. So we'll see all of those. This is the basic overview of CNS, which is divided into the brain and the spinal cord. Brain again consists of the cerebrum, cerebellum, and the spinal cord. Spinal cord is surrounded by this meninges, and it has these nerve roots and the cords and nerve roots. And the basic key functions of the brain is the integration, regulation, homeostasis, and coordination. So this is the gross picture of the brain, which shows the different lobes, which is divided by the central sulcus, into frontal and the parietal lobe, and by the lateral sulcus into the frontal and the temporal lobe. And this is the occipital lobe, which in the inferior part of the brain, which has the brain stem, and this is the cerebellum. Now we come to the microscopy, where most of the neurosurgeons is unfamiliar of, which, like in the microscopy, what we see, the pathologist, the neurons, neuroglia, what are the different cells in the brain and spinal cord, and the meninges, choroid plexus. So this is the basic structure of the neuron, which is divided into the cell body, which is also called as soma. And these are the dendritic projections. And this is the axon. And this within the cell body of the neuron have this rough endoplasmic reticulum, which is also called as the Nissl bodies. And this these dendrites here take the synaptic transmission from the neuron which is above, and axon transmits it to the another neuron through this synaptic ends, synaptic terminals. As we all know that there are different types of neuron which are vary in their structure and function and also the genetic makeup. And this is the morphological classification of the neurons, which are 5 major types, which is unipolar, pyramidal neurons, multipolar, bipolar, and Purkinje neurons, which are located at different places in the CNS, which we see here. See, these are the cerebellar Purkinje neurons, these pyramidal cells here, and these are the cerebellar in the cerebellum, cerebellar granule neurons. Here, as we can see, there are cerebral cortical neurons here, which are can be seen in the brain parenchyma. Now, as we examine the neurons in the microscope, we use different stains. There are several stains to study the neurons, to study the pathology of the neurons. Here we see the Nissl stain, which is a stain which is done by the crystal violet stain. And here it highlights this Nissl granules in the neurons, which is present in the cell body. And here we can see the silver stain, which is also called as Bilskowski stain, which also highlights the dendritic part of the neurons. As we can see here, the thread-like projections. And we have this another stain to study the myelination of the neurons, which is a Luxel fast blue stain, which helps in the study of the myelination of the neurons, demyelinating diseases in the neurons. Then we come to the different glial cells, which are non-neuronal cells present in the nervous system. And these cells cannot generate the action potential. As we all know that neurons can generate the action potential and helps in the generating action potential and transmitting the impulses. But glial cells on the other side are non-neuronal cells. And they cannot generate the action potential, and they do not have this chemical synapses. And these neuronal support system, they act as a neuronal support system which react to the injury and they regulate the metabolism. Here we can see there are several neuroglial cell types and their function. We go one by one. Like in the central nervous system, we have astrocytes, ependymal cells, oligodendrocytes, and microglia. And in the peripheral nervous system, we have the satellite cells and the Schwann cells. First, we'll see in the central nervous system, astrocytes. As we all know, astrocytes helps in maintaining the blood-brain barrier. And this controlling the levels of the neurotransmitter around the synapses, and they regulate the ion and providing the metabolic support to the neurons. And ependymal cells, when we come to the ependymal cells, these ependymal cells are the ciliated cells, ciliated columnar cells. As we can see here, these are the columnar and they have this cilia. They line the spinal cord and the ventricles of the brain. And they involve in producing the cerebrospinal fluid. And next, we come to the oligodendrocytes. These cells myelinate CNS axons. As we know, there are neurons which have the axons and they are myelinated. Some neurons which are myelinated and some neurons are unmyelinated. So in the CNS, whatever axons we have, they are myelinated by the oligodendrocytes. So oligodendrocyte myelinate the axons which are present in the central nervous system, and Schwann cells on the other side myelinate the axons which are present in the peripheral nervous system. So, and microglia, these are the brain's immune cells. We also can say it as a macrophages, which remove the dead cells and pathogens by phagocytosis. As we have a macrophage in a peripheral blood, Like that, we have a microglia in the brain. And peripheral nervous system, we have a satellite cells which surround the neuronal cells bodies in the ganglia and regulate neurotransmitter levels. Schwann cells, as we have seen, they myelinate the neurons in the peripheral nervous system, and they maintain and regenerate, helps in the regeneration of the neurons. We come to the astrocytes. These are the as we can see here, these are star-shaped, star-like cells, resemblance of the, and they are, responsible for the chemical environment for signaling of the signaling to the other axons, signaling between the different astrocytes for the uh, like as we know, they have maintained the homeostasis, so they have to um, respond to the environment. So for that signaling, the astrocytes form this star shaped, and they are also responsible for the blood brain barrier. And whenever there is an insult to the brain, these astrocytes are also respond to that, and um, they also responsible for the reactive changes. As we all know that these astrocytes are abundant in the brain, and they communicate via the gap junctions. Gap junctions are the communication between the two cell types. And as here we can see there is a vessel, and this astrocyte is connected to this vessel and forming the blood-brain barrier. Whenever there is a reactive gliosis, these astrocytes increases in the number and in the size, and they respond to that. So we can study this with a special stain which is called the glial fibrillary acidic protein. This is the immunohistochemical marker which we can which helps in studying the astrocytes in the brain. And we also can study the astrocytic lesions with this marker, immunohistochemical markers. We come to the oligodendrocytes, which are derived from the neuroectoderm. And these are common cells in the white matter. And they have the cytoplasmic processes of oligodendrocyte, which wrap around the axons. And these cells here we can see are the small round and they have this lymphocyte-like nuclei with dense chromatin. And these oligodendrocytes damaged in leukodystrophies. And certain viruses also infect the oligodendrocytes, which helps with oligodendrocytes, as we know that it helps in myelination of the neurons. If oligodendrocytes are damaged, it causes the demyelinating disease also, leukodystrophies. Difference between the oligodendrocytes and Schwann cells. Oligodendrocyte myelin forming are the myelin forming cells in the CNS, and Schwann cells are the myelin forming cells in the peripheral nervous system. And oligodendrocytes are derived from the neuroectoderm, and Schwann cells are derived from the neural crest. Coming to ependymal cells, these are the cuboidal to columnar, as we have seen, and they line the ventricular system in the brain, all the ventricle and the spinal canal. And they have this cilia. Cilia are these hair-like projections here on the surface, and they have this apical surface to it, which provides the barrier between the brain and the CSF. We come to the microglia in the CNS, which is responsible for the phagocytosis. Here we can see there is neurophagia, where when there is anything anything stimuli is there, or any foreign body, all the new microglial cells come around it, and they try to eat it. So it is called the neurophagia, which involves in the reactive gliosis, and they form the reactive oxygen species in the process of phagocytosis, and these cells, microglia, are derived from the mesoderm. Coming to the choroid plexus, these are specialized cells which are derived from the ependyma, which secretes the CSF. So CSF, we know that it is secreted by the choroid plexus. Papillae, and this choroid plexus in the histopathology, if we see in this image, histopathological image, we see it like this. They have this papillary projections, and they are lined, these papillary projections are lined by this cuboidal epithelium, which is covering the by this vascular pores. There are vessels, as we can see here, capillaries are here, and are surrounding that there is a papillary projections, which are lined by these cuboidal cells. And these choroid plexus are these tight junctions which maintain the CSF barrier also. And about 20 ml of CSF is produced per hour. Normal CSF volume is 140 ml, 25 ml in the ventricles, and rest of the in the subarachnoid space. Here we coming to the lining of the brain. Lining, which is fibrous dura, which is closely attached to the inner skull. This dura is attached to the here skull, and then after that there will be a dura which is closely attached. Then there comes the leptomeninges. Leptomeninges includes arachnoid and the pia mater are made up of meningothelial cells. As meningothelial, these we know meninges are composed of meningothelial cells. We know that there are certain tumors which are derived by meningothelial cells. Example, meningiomas. So this leptomeninges are made up of meningothelial cells and connective tissue. Then there is a thin translucent arachnoid membrane. Here it is marked, and which drapes over the brain here. And then here it is, pia mater, which thinly covers the brain parenchyma. The delicate pia remains closely attached to the entire cortical surface, and in inwards, see here we can see it inwards in around the arteries as they penetrate into the brain here. And CSF circulates in the subarachnoid space between the arachnoid and the pia mater. CSF flows out of the subarachnoid space into the dural sinuses. Here, dural sinuses, and through the arachnoid granulations and protruding into the sinuses. These are the arachnoid capsules which are attached to the sinuses and which are surrounded by the endothelium. Now coming to the spinal cord. Spinal cord is also surrounded by the dura mater, subarachnoid space, pia mater, and dorsal nerve roots. These are the dorsal nerve roots, these are the ventral nerve roots, and this is the linea splendens. Now, coming to pathology, which we see in the neurons, like apoptotic neuronal cell death, hypoxic or ischemic neuronal necrosis, neuronal loss in the neurodegenerative diseases, axonal pathologies, axonal degeneration following neuronal death, and then neurological changes following axonal damage. And there are certain diseases where we can see the neuronal inclusions. Neuronal apoptosis plays a major role in the pruning neurons, which are during the CNS development. As we see, certain neurons will be degenerating. So that process is by the apoptosis, often causes by the withdrawal of the trophic factors, DNA fragmentation, karyorrhexis, and condensation into the apoptotic bodies. These are the apoptosis in the neuroblastic tumor. And these are the fragmented chromatin in the dorsal root ganglion, which will be, this is the image which is seen in the electron microscopy, where we can see the fragmentation of this chromatin. Neuronal injury, acute neuronal injury, which is seen in 12 to 24 hours post hypoxia or ischemia. And in though in that period, eosinophilic cytoplasm and pycnotic nucleus known as a red neuron is seen in the this neurons. So neuron in the region C1A, as we can see here, cortical layers 3, 4, 3, 5, and Purkinje cells are specially vulnerable. Here on histopathology, we can see it as a discoloration within the proximity here in the C1A region. If ischemia is severe or it is prolonged, glia also dies, and the necrotic region is cleared away by the macrophages. This region, which we can see here as a discoloration, that is the region which is cleared by the macrophages. And these are the red neurons which I was talking about with the red nucleus. Then comes the chronic neuronal injury, which occurs in the neurodegenerative diseases. And this in the chronic neuronal injury, slow loss of neurons with reactive gliosis occurs. There is a time in the chronic insult, in the chronic disease, there is a time for neuron to react more. So there is a reactive gliosis occur, which is seen in Alzheimer's, Parkinson's disease, etc. Here we see the axonal degeneration, which is following the neuronal loss. Here, this is the Luxel fast blue myelin stain. As we have discussed, this stain is used for studying the myelination of the neurons. And here it is a CD68, which is a macrophage marker, which is highlight the axonal degeneration in the cross and uncross sections of the spinal cord in the amylotropic lateral sclerosis disease. We come to the neuronal inclusions in the neurodegenerative disease, which are the either cytoplasmic inclusions or nuclear inclusions. Cytoplasmic inclusions in the Alzheimer's disease are the neurofibrillary tangles, and in Parkinson's disease are the Lewy bodies. Here we can see a Lewy body in the Parkinson's disease, which is seen in the brain parenchyma, and the Pick's body is seen in the Pick's disease. And these are the when we come to the nuclear inclusions, it is seen in the Huntington's disease. These are the ubiquitin inclusions, and these are the nuclear present in the nucleus of the cell. Coming to pathology of the glial cells. Now, up till now, we were seeing the pathology of the neurons. Now we come to the pathology of the glial cells. How the glial cells react. Reactive astrocytosis. As we have seen that the glial cells help in the maintaining the neurons. So these cells, whenever there is any insult to the neuron, this glial cells also react. So whenever reactive astrocytes occur, a non-specific reaction to infections, seizure, autoimmune diseases, or infarction, and in the reactive astrocytosis, what happens to the astrocytes? How astrocytes react? Astrocytes undergo hypertrophy and hyperplasia. Due to the insult, there will be a stimulation to the astrocytes, which react by hyperplasia and hypertrophy. And the fibrillary gliosis occurs. Gliosis means there will be proliferation of astrocytes and proliferation of the reactive astrocytes. Then the next comes the pyloid gliosis, which is seen around the spinal cord cavities, which is called syrinx. And the other long-standing reactive gliosis in the cerebellum and the hypothalamus. And Rosenthal fibers, these are the pink eosinophilic long fiber-like thing here we can see. These are the Rosenthal fibers, which is seen in the chronic gliosis. Oligodendrocytes and microglia responses. How does oligodendrocytes respond? Oligodendrocytes injury leads to demyelination. Because oligodendrocytes are responsible for myelination, when oligodendrocytes undergoes denaturation, it leads to demyelination. Then microglia activation form rod cells and neurophagia. Here we can see there are the surrounding this neuron, there are this macrophages, microglia coming around it, and it is causing the neuronophagia. Glial nuclear changes in the progressive multifocal leukoencephalopathy. In the JC virus immunostain, we can see that it is stained oligodendrocytes, staining the nuclei of the oligodendrocytes, and infected oligodendrocytes are undergoing this. Here we can see the light staining microglia coming and surrounding these oligodendrocytes and causing the neurophagocytosis. Coming to summary, neurons are the signal transmission, show apoptosis, red neuron change, and inclusions in the chronic neurodegenerative diseases. And neuroglia are the astrocytes, oligodendrocytes, and ependymal cells. Microglia in the CNS causes CNS macrophages and neuronophagia. And choroid plexus produces the CSF and maintains the blood-CSF barrier. Meninges, dura, arachnoid, and pia mater, and CSF circulates in the subarachnoid space. Neuronal pathology, acute and chronic injury. In acute injury, between 12 to 24 hours post ischemia, we can see the red neurons, and chronic injury, neuronal loss, and gliosis, which is seen in the Alzheimer's, Parkinson's disease. Inclusions, we can see neurofibrillary tangles and Lewy bodies, Pick's bodies, and nuclear changes in the Huntington's disease. Glial pathology, reactive astrogliosis, pyeloid gliosis, microglial activation in infections and neurodegenerations, glial nuclear changes in the progressive multifocal leukoencephalopathy, which is a viral disease. And then we have seen the special stains, which stains the different part of the neurons and microglia. Thank you.
Thank you very much. A lot, this is memories for me. A long, long time ago, that pathology was given in medical school, and I enjoyed it. Let's see if we just have a few people here, but maybe they have a question. Does any panelist have a question or comment they want to tell Khan? They want to ask Khan, Dr. Khan? I don't believe so. Well, we thank you very much, Dr. Khan. We're going to have this a series, so we're going to have another one next week. We'll build up an audience. Don't worry, I'm determined. I'm determined for this group to succeed, because I think there's a place for kids that don't know what they want to do. They want to go to pathology, they want to go into neurosurgery, they want to go into internal medicine. And it's important to talk to people like you that can give them some direction and some taste of what it's like. I can remember that time of uncertainty. I was trying to decide between orthopedics and actually neurosurgery. I didn't entertain neurosurgery too long during internship because I'm not a precise type of person. I'm not dexterous microscopically. I'm dexterous with doing things like setting bones. It doesn't take a lot of physical dexterity, although it helps. But as far as micro dexterity, have you done much work under the microscope, Doc? You must do a lot in pathology. You're muted or something.
Yeah, I work on microscope.
You like the microscope?
Yeah.
You must love it. You spend probably most of your day at the microscope, correct?
Without microscope, pathologist cannot do anything.
Yeah, you're stuck. You're stuck.
Yeah.
So you spend all your time at the microscope. And I just wasn't suited for it. Because I took hand surgery of rotation, which of course uses the microscope also. but just from having one cup of coffee, you could see my hand shaking under the microscope. Obviously, that doesn't affect you. Do you have to alter your diet? Do you drink coffee at all?
I drink tea.
Does tea make your hand shake? You know how coffee makes to stimulate. It's stimulant, actually. I mean, you know, it's a kind of
Yeah, it
stimulant.
is
But
stimulant.
I'm sure there's some neurosurgeons that know how to handle it, or their bodies handle it without shaking. So you have no problems with your hand shaking.
No, no.
Yeah, you see under the microscope, obviously a shake would be magnified, and it doesn't look good. Even scrubbing as a scrub tech, which most medical students do, you could see me shaking. I would try to retract. I'd be shaking. It was
Yeah.
embarrassing. Yeah, the more I tried not to shake, the more I shake. That never has happened to you, right? Have you ever seen anyone like that?
No.
Oh my God, I'm an anomaly. I'm a case study. Well, anyways,
My grandma, like my grandma had that thing that her hand, whenever she holds anything, her hand used to shake.
well, uh, you've got to be comfortable under the microscope.
Hmm.
I never really was. I never really probably had a passion for the microscope. You probably just loved it from the start,
Yeah.
right? But
Yes.
uh, that's the way it is. But I tell you, Doc, I'm going to tell you something you're going to thank me for. Okay, there's a new thing on Zoom which is earth shaking that not many people appreciate it, like me, because I spend all day on Zoom and I can see little things. There's what's called an AI companion. Now, do you go to your screen? Do you see the option of AI companion? No, at the bottom of the screen, do you see AI companion? No.
No.
Okay, go. You have an apps option there, apps. Click on
Hmm.
the apps option. Maybe it's under there.
Zoom app.
Yeah, Zoom app and look under AI companion.
Uh,
Okay,
uh,
do you see what I'm typing? Okay, do you see that on your screen? The AI app on the chat
oh,
box?
yeah, yeah, here.
Do you see it?
AI companion, yeah.
You see how about neurosurgeon? You see that?
Hmm.
This is an AI you can use without leaving the screen of this is
Webinar summary.
fantastic. Yeah, I can ask like what's a glial cell while you're lecturing because I don't want to stop you. You're rolling. And it'll like I'll say now, like I'm gonna say, what is a glial? And you see the screen now when I'm typed what I typed, what is the glial? Do you see that? In the chat box, do you see that? No?
No.
Okay, so it must be a personal thing for me, but it's showing
Hmm.
up in
Yeah.
your chat. You know the white part? It's your chat box. That's what shows up for me. You must be seeing the regular. Oh,
Hmm.
you can see that you are typing. Oh, okay. Yeah, okay. So it's a
Actually,
private.
I have to go somewhere. Can I leave?
Oh, okay. I'm sorry. I'm going to keep you
I'm
up. That's
sorry.
okay. Okay. We'll leave it. We'll discuss this later. But
Yeah.
I'm gonna type in. I'm gonna get off this, and I'm gonna
Okay.
type in what it is. Okay. Let me put it in the chat.
It's Saturday evening here, so I had to.
You're gonna go to the nightclub now, right?
No, no, not.
Called, okay, it is called AI Companion. Do you see what I wrote?
Yeah, it is called. Yeah.
Look it up. Look it up. It's a game changer, man. You hear that a lot in the on the internet. Game changer. This is great. Having a private. Do you know ChatGTP at all?
Yeah, yeah, I use it. I
Yeah.
use it.
Oh,
frequently.
I use it all day. Now you can put it on the screen and Zoom, and you won't have to leave it and look at ChatGTP. So uh, I won't be able to sleep tonight. Okay,
Thank,
thanks, Doc, and we'll see you next week.
thank you. Yeah.
Thank you. Bye-bye. I'm going to stop this recording. I'm going to stop the stream, and we're off the stream. Okay. Good night.